In a modern intensive care unit, physical therapists use high-tech monitoring and complex biomechanics to mobilize patients to the edge of the bed. This specific strategy, using movement as a primary clinical intervention, dates back over 5,000 years. Around 3000 BCE, Taoist priests in China codified a system called Kung Fu. This was a structured regimen of breathing routines and static posturing designed specifically to relieve pain and balance internal bodily functions. In ancient Greece, the physician Hippocrates formalized this further. He was among the first to document the principle of musculoskeletal atrophy, observing that inactivity causes the wasting of muscles and bones. To mitigate this, he prescribed targeted exercises and manual friction. By the 2nd century, the Roman physician Galen had institutionalized these concepts. He used regulated gymnastics to rehabilitate wounded gladiators, treating moderate exercise as a necessary tool to raise body temperature and facilitate physiological recovery. However, following the collapse of the Roman Empire, mainstream Western medicine largely abandoned active healing. For centuries, the medical establishment prioritized passive, often dangerous interventions like bloodletting, purging, and the enforcement of total bed rest. The logic of movement-based healing disappeared from standard medical texts, remaining a lost philosophy for nearly a millennium. It remained dormant until the combined weight of industrialized warfare and viral epidemics forced the medical world to rediscover it. World War I introduced the destructive force of modern artillery and trench warfare, producing a volume of severe orthopedic and neurological wounds that the existing medical system was not equipped to handle. By 1917, the U.S. Surgeon General's office realized that pensioning off thousands of permanently disabled veterans was economically unsustainable. The military required a functional solution. They had to restore these men to physical independence. The solution was a specialized civilian workforce known as reconstruction aides. These were women trained in Swedish massage, hydrotherapy, and corrective exercises, specialized techniques that had been evolving in Europe but were still rare in American medicine. Photographic records from 1918, like this group portrait at Willow Bank Hospital, show these pioneers in the field. Their work provided the first large-scale clinical evidence that targeted movement, rather than the traditional prescription of rest, restored wounded soldiers. These women, led by pioneers like Mary McMillan, returned from the war to find a profession in its infancy. In 1921, they founded the American Women's Physical Therapeutic Association to standardize their training and clinical methods. The success of the reconstruction aids provided a data-driven rebuttal to the medical reliance on passive recovery. By returning disabled veterans to the workforce, they proved that active rehabilitation was a social and economic necessity. As the war ended, the polio epidemic surged. The virus targeted the anterior horn cells of the spinal cord, causing flaccid paralysis and muscle atrophy. To combat this, therapists developed manual muscle testing. By grading the strength of remaining muscles, they designed exercise programs that trained healthy fibers to compensate. The scale of the epidemic was overwhelming, requiring cavernous wards filled with iron lungs to keep paralyzed patients breathing, as seen in this 1950s hospital ward. Public awareness shifted when President Franklin D. Roosevelt sought treatment for his own paralysis. His high-profile use of hydrogymnastics at Warm Springs, Georgia, seen here, demonstrated the clinical value of exercise in buoyant, mineral-rich water. World War II created a simultaneous surge in orthopedic casualties. Physical therapy leaders like Emma Vogel expanded the profession's scope to include specialized rehabilitation for amputations, burns, and nerve injuries, utilizing machines like these pulley and weight systems. By managing a two-front crisis, combat injuries abroad and a viral pathogen at home, physical therapy transitioned from a temporary wartime service into a permanent medical science. In 1955, Jonas Salk's vaccine was approved for production. The resulting national vaccination program, pictured here, virtually eradicated the disease that had shaped physical therapy for decades. But the profession did not disappear with the virus. It continued to grow, though therapists were still legally defined as technicians who could only provide treatment if they had a direct referral and specific orders from a physician. The next evolutionary shift occurred during the Vietnam War. A severe shortage of orthopedic surgeons on the front lines forced the U.S. Army to authorize physical therapists to evaluate and diagnose neuromusculoskeletal conditions independently. This military pilot program provided the clinical proof that therapists could safely manage patient triage and diagnosis without physician oversight. This model provided the foundation for the civilian direct access movement, beginning a multi-decade transition toward professional autonomy. Today, the profession has moved from reconstruction aides to doctors of physical therapy. These are autonomous practitioners who use evidence-based research to prevent injury and restore mobility, often reducing the need for surgery or long-term medication. The history of physical therapy defines a shift in the goal of modern medicine. Success is measured not merely by the preservation of a body, but by its restored capacity to move and participate in life.